Okay, good afternoon, guys. We are going to begin chapter 26, which is the head, face, eyes, ears, nose, and throat. We are looking at approximately 80 slides, so we want to roll through this as quick as possible. I've broken it up into two different sections. This is video A, so if you want to pace yourself and get through as much as possible, they're about 10 minutes, 10 to 15 minutes long. So let's begin with chapter 26. How do we prevent injuries to the head, face, eyes, ears, nose, and throat? They are prevalent in sports, especially collision and contact sports. And we always say football, but that is a good one. Hockey is another big one. Hockey didn't have head gear back in the day, and we'd have broken teeth, ears, deformities, nose deformities. So it's definitely something we have to worry about in contact sports. Education and protective equipment are critical in preventing injuries to the head and face. Head trauma results in more fatalities than any other sport, and we see that. We know that it happens. And morbidity and mortality associated with brain injury have been labeled the silent epidemic. And we see that with poor tackling in football. We see that with hit and knockout in sports like basketball and hockey. Those are big. And lacrosse. This is part of the anatomy, and you should be familiar with this because you watched your anatomy videos on Monday that were the cranial bones and the facial bones. Assessment of head injuries. When we look at injuries of the head, they occur as a result of a direct blow, sudden snapping of the head forward, backward, or rotating side to side, similar to like what happens in a car accident. May or may not be result in loss of consciousness, disorientation, or amnesia. Most coordination or balance deficits are cognitive deficits, so of the brain. Things that happen usually occur to the brain, which is the cognitive side of things. When I was saying consciousness and I said concussions, concussions are major, so that's something you need to note. May present as a life-threatening injury or cervical injury if they are unconscious. So what is the history? If you're a trainer and you have someone you think is injured, you have to walk through your history with them. Determine if there's a loss of consciousness and or amnesia, which is forgetting things. Additional questions. Responses will depend on level of consciousness. Do you know where you are and what happened? Okay, what happened and where you are currently. Can you remember who we played last week? Retrograde meaning of the past. Okay, retrograde amnesia of the past. Can you remember walking off the field? Antegrade amnesia, and this ante means just right before. So anything, just like in poker, you have to ante before you can play, and that is right before you can play your hand. So ante means right before. Does your head hurt? Obviously. Do you have pain in your neck? Do you have tinnitus, which is ringing in the ears? Ringing of the ears is tinnitus. So make sure tinny and the sound, the reverberation of the ears. And can you move your hands and feet? Period. Without pain. Observation. What do you see versus what do you ask them? Is the patient disoriented and unable to tell where he or she is at, what time it is, date it is, or who the opponent is? Is there a blank or vacant stare? Can the patient keep their eyes open? When we have the student in the middle school who has seizures, she goes into a vacant stare. She actually turns a different color a little bit in her skin tone, but she cannot communicate with you before she gets ready to have a seizure. So that's a good indicator that something's happening neurological. Is there a slurred speech or incoherent speech? Are there delayed verbal and or motor responses? And are there gross disturbances to coordination? Gross meaning major, big skills like throwing, kicking, running. Is there a disturbance there? Are they having an inability to focus attention? Is there a memory deficit? And does the patient have any normal cognitive function? Normal emotional responses. How long was this patient? Affect abnormal, so how they're reacting to things versus effect. And is there any swelling or bleeding from the scalp that you need to note? Fluid in the ear is a big indicator of some kind of brain trauma. Palpation, feeling, neck and skull at the point of tenderness and deformity, and then there's some special tests that we need to check with. There's a neurological exam, so assessing for cerebral testing, cranial nerve testing, anything within the sensory motor reflex. Eye functioning. This is the acronym I want you to remember, PEARL. And this stands for pupils equal and reactive to light. Pupils equal and reactive to light. Okay? Do they dilate or have irregular pupils when they're not supposed to? And do they accommodate for light for certain situations? Eye tracking, and that's why you have your eye doctor take a pen, a light pen, and move your eyes back and forth because they want to make sure you have a smooth tracking. And then blurred vision. Can they see clearly or not? Balance test. First balance test we're going to talk about is the Romberg test, and it assesses the static balance. So their ability to remain and stand motionless. And there's a couple different ones, but it's primarily in the foot position. And this is a perfect example. She is, it almost looks like you're walking the line, but you're standing still. You're not moving past that point. Next one is BESS, Balance Error Scoring System. It is a clinical battery of tests that utilizes different stances on both firm and foam surfaces. And you check any errors that would take off on your feet or to make sure that they're balanced. And it looks like there's quite a few. So over here you see without foam, and then you see with foam. So you're checking to make sure that they get an accurate score. Coordination test, finger to nose. We do some of these as adults. If you have been in an auto, if you've been pulled over in the car, if they are checking to see if you're sober or not, and they'll do a finger to nose, can you pull it, and heel to toe walking. This tells you, it tells police officers if there's an injury to the cerebellum, or usually if you are sober or not. So they kind of go twofold. I mean, you can test similar in sports injuries to the brain. Cognitive test, how you establish impact on head trauma. On or off the field assessment, do your serial sevens, months in reverse order. So you're talking to them. They have to give you answers to quizzes, just verbal recognition. Test recent memory. What was the score of the game? What did you have for breakfast the day of the game? Give them words and then make them recall those words. Neuropsychological tests, so of the brain, of the neurons and the brain. Standardized assessment of concussion, which is the SAC, is a brief mental status test. You are our biggest key, and when you're going to be quizzed, concussion, concussion, concussion is what you want to think about when we're in this chapter. But this is going to be a big test to test for you. You used to assess orientation, immediate memory recall, concentration, delayed recall on and off the field. So here is our NAS. Our other assessment tools have been designed to assess short memory, working memory, attention, concentration, visual space capacity, verbal learning, information processing, speed, and reaction time. We can do a computerized neuropsychological test, and you can do that through ANAM, CogState, Concussion Resolution Index, which we abbreviate CRI, and IMPACT, literally immediate post-concussion assessment and cognitive testing. So let's recognize specific head injuries. We're going to go into detail here, and I will give you a heads up that it is going to get, some pictures are going to be a little bit more visual than others, so pay attention, and Noelle, if you need to look away, I understand. Skull fracture. We're looking at a few skull fractures here. This is depressed, this is compound, this is a hairline where it's very thin, and this is subdural hematoma where there's bleeding in the brain. Okay? So what is the etiology of a skull fracture? It's usually caused in blunt force trauma. This would probably be like a hammer or something going through the skull. Sports, it's a little odd because you're not going to have a hammer in a sport, but it's going to be a deep depression groove. Signs and symptoms: severe headache, nausea. Palpation may affect a defect in the skull. This would definitely be a defect in both parts of the skull. Maybe blood in the middle ear, ear canal, nose. Ecchymosis, which is the bruising around the eyes, or behind the ear, battle sign. Cerebral spinal fluid may also appear in the ear and nose. Management: immediate hospitalization and referral to neurosurgeon. If it is within the brain, there's probably going to be damage and they need to take care of that. Cerebral spinal concussions, mild traumatic brain injuries. You guys, I'm telling you again, concussion, concussion, concussion. So remember this section. Major public health concern with return to play decisions remain most challenging task for any sports medicine clinician. Typically, in order to return to play in Acacia Sports, you have to have a doctor's approval if you went out with some kind of a concussion. The result is usually a direct blow, acceleration or deceleration of forces producing shaking of the brain. Car accident, your brain hits, your brain goes forward where your head's going backwards, and then it ricochets back and forth off of your skull. Signs and symptoms, changes in level of consciousness, post-traumatic amnesia, Glasgow Coma Scale, so they can run that for you. Concentration deficits and attention span difficulties, balance and coordination problems, and then that you must monitor any of your duration signs and symptoms. So checking to make sure if you're nauseous. If you have a concussion, most times they tell you to not fall asleep right away because they want to make sure that you are stable and you are of a level of consciousness that is okay. More signs and symptoms. There's two primary symptoms, loss of consciousness and post-traumatic amnesia. On a scale, they can decide if you can return to play and typically involve that loss of consciousness or amnesia. Recent classification systems have included concentration deficits, attention span difficulties, balance and coordination in addition to the loss of consciousness amnesia. We place more emphasis on all signs and symptoms and maybe more logical approach than just loss of consciousness and amnesia. Okay. Using signs and symptoms immediate post-injury and 15 minutes post-injury to provide an estimation of injury severity has also been suggested. The third approach in this involves recovery of symptoms, so making sure that they can get through their neuropsychological testing and any kind of postural stability. How do we manage a concussion? It's decision to return any patient to competition following a brain injury is definitely a difficult one, and you need to take consideration into it. If it's a football player and it's in the middle of the game, they take a hit, they don't know what game they're in, they don't know what state they're in, they're mumbling. As the trainer, take that helmet and hide it. Do not let that athlete return to play. And you need to make the decision and tell that coach, we're not going to have this athlete return to play. If any loss of consciousness occurs, the athletic trainer must remove the patient from competition. It's a liability. With any loss of consciousness, LOC, a cervical spine injury should be assumed. Usually the EMT, EMS is going to come. The BESS and the SAC, so our balance tests, should be performed to determine readiness to return to play. A number of guidelines have been established in an effort to aid clinicians in their decision, and return to play, our normal baseline, requires approximately 3 to 5 days. For some, it can be even longer. All post-concussive symptoms should be resolved prior to returning to play. So if they are nauseous, still nauseous, you're not going to put them back in the game because you can compound that concussion. It's going to be even worse. Reoccurrent concussions can produce cumulative traumatic injury to the brain, which we don't want to do. Following any initial concussion, the chances of a second episode are 3 to 6 times greater, and they must be able to determine the need if you have to go to a physician and decide if the patient should return home or go to a hospital. In the past, rest was always deemed the best for treatment. In the dual task rehab strategies, it's best being explored right now. It involves posture stability and cognitive tasks, so being able to do the physical with the brain, physical with the mental right here. Little evidence is available involving divided attention task, balance training, neurocognitive tasks, and simultaneous perform of both. More research is necessary to establish efficacy and treatment method, which patients are best candidates, how soon should the technique be introduced. So let's go past the fact that we've had a concussion. Now we're into the post-concussion syndrome. It is when it follows a concussion. It may be associated with the MHIs that don't involve loss of consciousness. So making sure that you are available, that your brain is still concussed, or that you had a severe, could be like a car injury, concussion, and you're still being treated for that. Signs and symptoms, they complain of a range of post-concussion problems, so headaches, lack of energy or lack of concentration, anxiety, giddiness, fatigue, memories, obviously a loss, may begin immediate following injury and may last for weeks to months. Athletic trainers should treat symptoms to the greatest extent possible, return to patient to play at all signs and symptoms have completely resolved. Second impact syndrome, and you can see that's right here. The injury occurred here, but the brain shifted back and forth, and that's what causes second impact syndrome. Rapid swelling, herniation of the brain. It may be a minimal and not much contact with the brain, which is the cranium, or it disrupts the brain's autoregulatory system and can lead to swelling, pressure, etc. Signs and symptoms, there's sometimes they do not have loss of consciousness but may look stunned, and within 15 seconds the injury of the patient's condition degrades rapidly. How do you manage it? Life-threatening, you need to get that addressed and get them to an emergency facility and manage with the best treatment through the athletic trainer's perspective. Next video will continue on.